When comparing Original Medicare combined with Medigap to Medicare Advantage, several important differences stand out for the 2025-2026 period. Original Medicare plus Medigap typically offers greater freedom to choose providers, allowing beneficiaries to see any doctor or specialist who accepts Medicare. In contrast, Medicare Advantage plans often have network restrictions, which may limit provider choices and could result in higher costs if care is sought outside the network. Premiums can also vary significantly between these options, with Medigap policies generally requiring additional monthly payments. Updated comparison tools, such as the Medicare.gov Plan Finder and the Quality Care Finder, make it easier for individuals to review coverage details, costs, and network risks. These resources empower beneficiaries to make informed decisions based on their healthcare needs and financial preferences. A comparative analysis of Medicare coverage, resolving Medicare Complete versus Medicare Advantage, and comparing price and benefits. Executive Summary: the central choice in Medicare coverage.
This analysis addresses a frequent and pivotal point of confusion for Medicare beneficiaries: the distinction between Medicare Complete and Medicare Advantage. The investigation immediately clarifies that Medicare Complete is not a separate federal program, but rather a brand name used by private insurers, such as Christus Health, for a specific Medicare Advantage plan. The user's query is a direct and understandable result of industry marketing, which often brands all-in-one plans with comprehensive-sounding names. This report, therefore, pierces this marketing veil to analyze the user's true decision. The choice is not between Complete and Advantage, but between two fundamentally different philosophies of Medicare coverage. We will analyze three distinct paths. 1. Original Medicare, Path 1. The government-run foundation, Parts A and B, which is financially incomplete on its own. 2. The flexibility path, Path 2. Original Medicare supplemented by a Medicare supplement, Medigap policy and a standalone Part D drug plan. 3. The all-in-one path, Path 3. A Medicare Advantage, Part C plan, which bundles Parts A, B, and typically D into a single managed care product. The central trade-off is stark. The Medigap path, Path 2, is characterized by higher fixed monthly premiums in exchange for unmatched provider freedom, any doctor in the U.S. who accepts Medicare, and extremely low back-end costs, virtually no copays. The Advantage path, Path 3, offers low or $0 monthly premiums and extra benefits, like dental and vision, but in exchange for using a local provider network and paying copays for services. This report provides a detailed, data-driven analysis of the price, benefits, and financial risks of these two comprehensive paths, concluding with an actionable framework to guide a beneficiary's personal decision. 2. Defining the landscape, resolving Medicare Complete versus Medicare Advantage. Clarifying the query: Medicare Complete is a brand, Medicare Advantage is the category. The term Medicare Complete is a specific product name, not a distinct category of Medicare. Research identifies the Christus Health Medicare Complete as a specific plan offered by the private insurer Christus Health. The plan's full name itself deconstructs the concept. Christus Health, the private insurance company offering the plan. Medicare Complete, the proprietary branded marketing name for this specific product. Insurers use other appealing names like Medicare Guardian 1, AARP Medicare Advantage Patriot 3, or AARP Medicare Advantage Essentials 3 to differentiate their products. Ostaming HMO, the official plan type, which defines its network rules, Health Maintenance Organization. This plan is an example of what the federal government officially calls Medicare Advantage, Part C. The user's confusion is not an error, but an intended consequence of a competitive insurance market where dozens of companies, like United Healthcare 6, Aetna 7, and Humana 8, must use branding to make their Medicare Advantage plans stand out. The foundational paths: an overview of Original Medicare versus Medicare Advantage. Having established that Medicare Complete is a type of Medicare Advantage plan, the real choice for a beneficiary is between the two main ways to receive Medicare coverage. Path A. Original Medicare. This is the traditional government-administered health insurance program established in 1965. 9. It consists of Part A, hospital insurance, and Part B, medical insurance. Nas mi som. Path B, Medicare Advantage. Part C, this is the private insurance alternative. These are all-in-one or bundled plans offered by private companies that contract with Medicare. A Medicare Advantage plan must cover all the same services as Original Medicare, Parts A and B, and most also bundle prescription drug coverage, Part D, 5. The third option, understanding the comprehensive coverage path. Comparing just Original Medicare, Path A, to Medicare Advantage, Path B, is an apples to oranges comparison. As the next section will detail, Original Medicare has significant financial gaps, such as 20% coinsurance for most medical bills and no cap on total out-of-pocket spending. To create a valid comparison, one must analyze the two complete coverage solutions that beneficiaries design for themselves. 1. The Medigap path. This path starts with Original Medicare, Parts A and B, then adds a Medicare Supplement Insurance, Medigap policy to cover the financial gaps, like the 20% coinsurance. It also requires adding a standalone Part D prescription drug plan. 2. The Advantage path. This path consists of a single Medicare Advantage, Part C plan that bundles Parts A, B, and, usually, D5. This choice is mutually exclusive. A beneficiary cannot have both a Medicare Advantage plan and a Medigap policies. 3. Analysis of Path 1. Original Medicare, the foundation. Before comparing the two comprehensive paths, it is essential to understand the foundation. Original Medicare by itself. Core coverage. What Part A, hospital, and Part B, medical, include? Part A, hospital insurance. Covers inpatient hospital stays, care in a skilled nursing facility, hospice care, and some home health care. Chenit, Part B, medical insurance. Covers medically necessary services like doctor visits, outpatient care, durable medical equipment, and preventive services. Critically, Original Medicare does not cover most outpatient prescription drugs, which requires Part D, nor does it cover routine dental exams, eye exams, or hearing aids. The primary advantage: unmatched provider, freedom and flexibility. The single greatest benefit of Original Medicare is its nationwide network. Beneficiaries can go to any doctor, hospital, or specialist in the United States and its territories, such as Puerto Rico and the U.S. Virgin Islands, that accepts Medicare. In most cases, no referrals are needed to see a specialist. This flexibility is ideal for individuals who travel frequently within the U.S., e.g., snowbirds, or who want to ensure they can access top-tier specialists or specialized treatment centers, like cancer centers, anywhere in the country without network restrictions. The critical disadvantage: understanding 20% coinsurance and unlimited financial exposure. The financial structure of Original Medicare is its greatest weakness and the primary reason it should not be used without supplemental coverage. For most Part B services, after a small annual deductible, the beneficiary is responsible for 20% coinsurance on the Medicare-approved amount. The critical flaw is this: Original Medicare has no annual maximum out-of-pocket MOOP limit. This creates a direct and potentially catastrophic financial risk. A 20% coinsurance on a $10,000 medical bill is $2,000. A 20% coinsurance on a $500,000 bill for complex cancer treatment is $100,000. This unlimited financial exposure, a relic of the program's 1965 design, makes Original Medicare functionally incomplete for modern healthcare. This structural flaw is the entire reason for the existence of the two solutions analyzed in this report. It creates the market necessity for Medigap policies, which pay the 20%, and the market viability for Medicare Advantage, which by law must include an out-of-pocket maximum. Cost analysis 2025-2026. A detailed breakdown. The following table details the baseline, non-optional costs set by the federal government for 25, along with official projections for 2026. Cost component 25. Cost 2026. Projected cost source as Part A. Premium $0 for most beneficiaries with 10+ years of Medicare taxes. $285 or $518 a month. For those who do not qualify. NEA, structural, not projected to change. 23. Part A hospital deductible, $1,676. This is per benefit period, not per year. NEA, projections not cited. 23 Cs. Part B, standard premium, $185,900 per month. $206.50 per month. A projected 11.6% increase. 25. Part B, annual deductible, $257 per year. $288 per year. A projected 12% increase. 26. Part B, coinsurance, 20% of the Medicare approved amount after the deductible. 20%. 14. Part B, out-of-pocket limit, none. None. 4. Note, Part B premiums are subject to an income-related monthly adjustment amount, IRAA, meaning high-income earners pay more.
Prescription coverage, costs and structure of standalone Part D plans. This path also requires purchasing a separate standalone Medicare Part D plan for prescription drugs. Cost, 2025. O, premium, varies by plan. The average basic monthly premium is estimated to be $46.50 to 23s. High-income earners pay an additional IRMAA 32. O deductible varies by plan, but no plan can have a deductible higher than $590 in 2025-23. Projections for 2026 raise this maximum to $615.38. The 2025 $2,000 out-of-pocket cap, Inflation Reduction Act. A monumental change, effective in 2025, simplifies the drug cost equation. All Medicare Part D plans, both standalone and those integrated into Medicare Advantage, now have a $2,000 annual cap on out-of-pocket drug costs. Once a beneficiary's out-of-pocket spending on covered drugs reaches $2,000, they pay $0 for those drugs for the rest of the year. This new cap acts as a great equalizer, as the maximum drug-related financial risk is now a fixed $2,000 for all beneficiaries, regardless of which path they choose. Total cost profile, modeling annual expenses. This path has 3 separate monthly premiums: Part B plus Medigap Plan G plus Part D. Example, monthly cost, $185, Part B, plus $175, mid-range Medigap Plan G, plus E46R50Cs, AVG Part D, equals I406.50 per month. This path represents a premium-heavy, low-risk philosophy. The beneficiary pays a high, fixed, predictable monthly premium, totaling $4,878 per year in this example. In exchange, they virtually eliminate variable medical costs. Their only out-of-pocket medical expense for the entire year, no matter how much care they receive, is the single Part B deductible, $257 in 2025. This is the peace of mind option, contrasting sharply with the pay-as-you-go model of Medicare Advantage.
V analysis of Path 3, Medicare Advantage, Part C, the all-in-one PACS path. This path is the private sector, bundled alternative to original Medicare, offered by companies like United Healthcare 6, Humana 8, and Aetna. The all-in-one model, bundling Parts A, B, and D. Medicare Advantage plans are required by law to cover, at a minimum, everything that original Medicare, Parts A and B, covers. Most plans, known as MADs, also bundle prescription drug, Part D coverage into the same plan. The advantage of price and perks. The primary appeal of Medicare Advantage plans lies in their low costs and extra benefits. Low premiums. Many plans offer a $0 monthly premium. It is critical to note, however, that the beneficiary must continue to pay their monthly Medicare Part B premium, $185 in 2025, to the government. Extra benefits. This is a major selling point. MA plans use the money they save through managed care to offer benefits that original Medicare does not cover. These commonly include O routine dental care, 4 O routine vision care, exams and eyewear, 4O hearing aids, 4 O fitness programs, gym memberships, 4O credits for over-the-counter, OTC, items. 4. The financial backstop, the role and range of the maximum out-of-pocket, MOOP, limit. This is the single greatest advantage an MA plan holds over unsupplemented original Medicare. By law, all Medicare Advantage plans must have an annual maximum out-of-pocket, MOOP limit for Part A and B services. Once a beneficiary's copays and coinsurance for medical services reach this limit, the plan pays 100% for covered services for the rest of the year. Cost range, 2025. The legal maximum MOOP a plan can have in 2025 is $9,350 for in-network services. However, many plans set their limits much lower. The 2025 enrollment-weighted average MOOP is $5,320.48. As the case study in Section 7 will show, some competitive $0 premium HMO plans can have a MOOP as low as $4,000 too. Plans, like PPOs, that offer out-of-network coverage typically have a separate, much higher MOOP for those services. The primary disadvantage: network restrictions and utilization management. The $0 premiums and extra benefits come with significant trade-offs, primarily in provider access. On network restrictions, beneficiaries must generally use doctors, hospitals, and specialists that are within the plan's network. OHMO, Health Maintenance Organization. These are typically the most restrictive plans. They require beneficiaries to use network providers, except in an emergency, and often mandate a referral from a primary care physician, PCP, to see a specialist. OPPO, Preferred Provider Organization. These plans are more flexible, allowing beneficiaries to go out of network, but at a significantly higher cost. Higher copays and a separate, higher deductible MOOP. Geographic limits. Coverage is generally localized to a specific service area, e.g., a few counties. This makes MA plans a poor choice for individuals who travel frequently or live in multiple states, as non-emergency care out of network may not be covered at all. Utilization management. MA plans use prior authorization. This means the insurance company must review and approve certain services, procedures, or medications before the beneficiary can receive them. This gatekeeping step, which does not exist in original Medicare 14, is a common source of beneficiary complaints and can lead to delays or denials of care. 6. Head-to-head comparison: original Medicare plus Medigap versus Medicare Advantage. The following table synthesizes the analysis from the previous sections into a direct, scannable comparison of the two comprehensive coverage paths. A comprehensive comparison of price, benefits, and risk. Feature path: 1. Original Medicare plus Medigap plus Part D path. 2. Medicare Advantage, Part C. Source as monthly premiums high. Sum of Part B premium plus Medigap premium plus Part D premium. Low. Must pay Part B premium, but MA plan premium is often $22. Provider choice. Maximum freedom. Any doctor hospital in the U.S. that accepts Medicare. No network. No referrals needed. Limited network. Must use plan's local network, HMO PPO. Referrals may be needed, especially for HMO duos. 10. Copays, coinsurance. Virtually none. After Part B deductible, $257, Plan G pays 100% of the 20% coinsurance for medical services. Pay as you go. Copays for PCP, specialist visits, and hospital stays are common, e.g., $0 PCP, $25 specialist. 2. Out-of-pocket max, MOOP. Extremely low. For medical services, the annual max is just the Part B deductible, $257. $2,000 for Part D drugs. Capped. Has a legal MOOP for medical services. 2025 AVG, $5,320. Max, $9,350. $2,000 for Part D drugs. 9. Extra benefits. None. Must pay 100% out of pocket for routine dental, vision, and hearing. Commonly included, most plans bundle dental, vision, hearing, and fitness benefits. 4. Prescription drugs. Separate, must research and enroll in a standalone Part D plan. Integrated, usually bundled into the plan, MAPD. 5. Travel coverage. Excellent. Nationwide coverage. Medigap Plan G includes foreign travel emergency coverage. Poor, generally limited to your local service area for non-emergency care. 10. Best for. Beneficiaries who prioritize provider freedom, travel, and predictable, though high monthly costs. Beneficiaries who prioritize low monthly premiums, value extra benefits, and are comfortable with a local, managed network. 11. Financial scenario modeling. Total annual cost profiles. To make this comparison tangible, we can model the total annual cost for 2 different beneficiaries. We will use the Medigap path example, $406.50 month premium, $257 medical MOOP, and 2 MA plan examples. The specific Christus plan, $0 month premium, $4,000 medical MOOP, 2, and a plan with the Dallas average MOOP, $0 month premium, $6,065 medical MOOP. Note, both paths share the same $2,000 maximum for drug costs, so that variable is a wash in a high-cost scenario. Scenario 1. The healthy, low-utilization beneficiary. Profile 2. PCP visits. 1 specialist visit, no hospital stays. Medigap path cost. $406.50 premium MO. Announcer 12, plus $257. Part B deductible, equal $5,135. Advantage path cost. Christus. $0 premium, Malzos. 2. $0 PC copay. Plus 1. $25 specialist copay. $1,000. Insight. For a healthy individual, the MA pay-as-you-go model is dramatically cheaper, saving this beneficiary over $5,100. The extra dental and vision benefits are a pure bonus. Scenario 2. The chronically ill, high-utilization beneficiary. Profile. A major surgery, multiple hospital days, frequent specialist visits, high-cost drugs. All medical costs hit the maximum cap. Medigap path cost. $5,135 total premiums, plus $2,000. Drug MOOP. Ixus. Total $7,135. The $257 medical MOOP is already paid within the premium calculation. A highly predictable, fixed cost. Advantage path cost. Christus. $0 premium, plus $4,000. Medical MOOP, plus $2,000. Drug MOOP, equals total $6,000. Advantage path cost. Dallas AVG. MOOP, $0 premium, plus $6,065. Medical MOOP, plus $2,000. Drug MOOP, EC total $8,165. Insight. This is the most critical analysis. The MA path is not universally cheaper for a sick individual. 1. The low MOOP Christus plan, $4,000, is the cheapest option of all. saving the beneficiary $1,135 compared to the Medigap path. 2. The average MOOP Dallas plan, $6,065, becomes more expensive than the Medigap path by $930. This demonstrates that while MA plans are almost always the cheapest option for the healthy, their value in a high-cost year depends entirely on the MOOP. A $0 premium MA plan with a high MOOP, e.g. $9,350, represents the highest risk financial option for a beneficiary with significant health needs.
7. Case study analysis, the Medicare Complete plan. We can now return to the user's original query and use the Christus Health Medicare Complete, HMO, as a perfect real-world case study of a Medicare Advantage plan. Plan. Spotlight, Christus Health Medicare Complete, HMO, 2025. Plan type, HMO, Health Maintenance Organization. This confirms it is a managed care plan that requires using a specific network of providers and likely requires PCP referrals. Service area, restricted to specific counties in New Mexico and Texas. This highlights the geographic limitation inherent in most MA plans. Detailed price and benefit analysis. The plan's 2025 Summary of Benefits provides a concrete example of the low-premium, extra perks model. Benefit. Cost. Christus. Health Medicare Complete. HMO. 2025 monthly premium $0. Beneficiary must still pay their Part B premium. Plan deductible $0. Medical max out-of-pocket, MOOP. $4,000 primary care copay, $0. Specialist copay, $25. Dental $0 for preventive. 2 exams, 3 cleanings, year. $2,750 annual benefit amount for comprehensive services, e.g. fillings, crowns. Vision $0 for routine exam. $200 annual allowance for eyeglasses or contacts. Hearing $0 for routine exam. Co-pays of $395 or $1,595 for prescription hearing aids. OTC benefit $135 per quarter for approved health and wellness items. Transportation $0 for 48 hours one-way trips to medical appointments. This plan exemplifies the MA trade-off perfectly. It offers a $0 premium, $0 deductible, $0 PCP copay, and rich extra benefits because it is a restrictive HMO. The insurer saves money by managing the provider network, and it passes those savings to the member. Its $4,000 MOOP is particularly aggressive and far more competitive than the national average, $5,120, $48, or the legal maximum, $9,350, $47, making it an attractive plan even for a high-utilization beneficiary, provided they are willing to stay within the HMO network. Finally, it is important to note that the extra benefits are valuable allowances, not comprehensive insurance. The $2,750 dental benefit, too, is generous, but it is a hard cap. Any costs above that are 100% out of pocket. These supplemental benefits are also the most likely to be reduced or changed by the insurer from one year to the next.
VATE. Market Insight. The Medicare Advantage landscape in Dallas, Texas. Providing local context for Dallas, a major service area for Christus Health, reveals the competitive dynamics that shape these plans, key providers, and plan availability. The Dallas County market is highly competitive, featuring plans from all major national carriers, including United Healthcare, AARP, 3, Humana 3, Aetna 3, Blue Cross, Blue Shield 3, HealthSpring, Cigna, 3, Christus Health Advantage 43. The top 3 plans by enrollment in Dallas County are offered by AARP, United Healthcare, and Humana, showing their dominant market presence. Typical cost and benefits in a competitive urban market. $0 premiums are the norm. In Dallas County, there are 38 Medicare Advantage plans with a $0 monthly premium. This intense competition forces insurers to offer a $0 premium as the standard entry ticket to the market. The MOOP trade-off. The average Medicare Advantage MOOP in Dallas County is 6,065.3. This local data reveals a common market dynamic. The Dallas market average, MOOP, $6,065, is significantly higher than the national enrollment-weighted average, $5,320, $48, and much higher than the Christus case study plan, $4,000. This suggests a common insurer strategy in competitive urban markets. Attract beneficiaries with the highly visible $0 premium, but compensate for that and for high utilization by setting a higher back-end MOOP. A beneficiary in Dallas who shops only by the $0 premium may be overlooking the $6,000+ financial risk they are accepting in a high-cost year. Yikes! Decision framework and strategic recommendations. The decision between the Medigap path and the Advantage path is deeply personal and depends on an individual's health, budget, and tolerance for risk. A framework for choosing your path. The following questions can help a beneficiary identify the path that aligns with their personal priorities. Key question: if yes, this path is likely a better fit. 1. Is keeping my specific doctor/specialist, who may be in high demand, my number one priority? Medigap Path 21-2. Do I travel frequently or live in multiple states for part of the year, e.g., Snowbird? Medigap Path 10-3. Is having a predictable, fixed monthly bill, even if high, more important to me than a low premium? Medigap Path 4. Do I have significant, complex health issues and want to ensure I can access any specialist or hospital in the U.S. without a referral? Medigap Path 14-5. Is having the lowest possible monthly premium my number one financial priority? Advantage Path 22-6. Am I generally healthy and use the healthcare system infrequently? Advantage Path 7. Are the extra benefits, dental, vision, gym, a major factor in my decision? Advantage Path 4-8. Am I comfortable using a defined network of local doctors and getting referrals from a PCP to manage my care? Advantage Path HMO 10. Final analyst insights and long-term considerations. 2 critical traps exist that make the initial Medicare choice at age 65 incredibly high stakes. 1. The Medigap trap. A beneficiary's 6-month Medigap open enrollment period, which starts when they are 65 and enrolled in Part B, is the only time they have a guaranteed issue right to buy any Medigap policy. After that period, an insurance company can use medical underwriting, meaning they can review pre-existing conditions and deny coverage or charge a much higher premium. 2. The MA trap. It is easy to join a $0 premium Medicare Advantage plan at age 65.4. However, if that beneficiary gets sick at age 75 and decides they now want the provider freedom of the Medigap path, they will be outside their guaranteed issue window. They will likely be denied Medigap coverage due to their new health conditions. This creates a one-way street. It is easy to move from Medigap to Medicare Advantage, but it can be difficult or impossible to move from Medicare Advantage back to Medigap. Final recommendation. The choice hinges on a personal assessment of risk tolerance, budget, and lifestyle. Choose the Medigap path for freedom and predictability. This path is best for those with significant health needs, those who travel, and those who can afford the high, fixed premiums and value the peace of mind of near-zero back-end costs. Choose the Advantage path for low premiums and extra perks. This path is best for those who are healthy, on a tighter budget, and are comfortable with the trade-off of a managed, local provider network. When choosing the Advantage path, the maximum out-of-pocket MOOP limit is a far more important number to shop for than the monthly premium. A $0 premium plan with a $4,000 MOOP, like the Christus case study, is a fundamentally different and safer financial product than a $0 premium plan with an $8,000 MOOP. Don't forget to like, share this video, and subscribe to the channel to support us in creating more meaningful content. Please leave a comment with your thoughts or any questions you have about faith. Sincerely,